Okay, welcome back everyone. So we will continue all of our fun learning with anatomy of primary teeth. So things to consider or things that we will review will be the general morphology and the implications of such morphology. So a couple of things to keep in mind in regards to primary dentition. Just remember that primary teeth resemble their permanent successors. They are not miniature permanent teeth, okay? So there are other factors to consider, especially during restoration. You have 20 primary teeth as compared to 32 permanent teeth. No premolars in the primary dentition. The primary molars are replaced by the premolars. So always remember that in case you're ever questioning during your clinical examinations. The permanent molars erupt distal to the primary second molars. So permanent molars erupt distal to the primary second molars. So when it comes to the eruption patterns of primary teeth, I don't want you guys to focus so much on the time frame in which they come in. I want you guys to focus more so on the sequence. So just know that the first set will more than likely be your lower central incisors and so forth, okay? So just focus more so on the timing. Anytime you see a range of the eruption time frames and things like that, just keep in mind that at least keep a reference of what the range is. Don't focus so much on the number because a lot of times you'll see that some children develop dentally faster than others. So just keep that in mind and kind of calm and soothe some of the parents' anxiety when it comes to teeth not coming in the time frame that is suggested. Okay. Also remember that they do come in a symmetrical pattern. Mandibular teeth do erupt first, as I stated before. So approximation of eruption schedule. So like I said before, there is a range as to when teeth do come in. So just keep that in mind. It won't always look like this at 8 months. It may be 10 months before they get their lower central incisors. So just keep that range in mind. Okay, so this particular patient here is about 6 to 8 months. So you start to see the central incisors erupting. Now, if this patient were born like this, so let's say within the first 30 days of life, and they came in like this, there's a particular term that is used when teeth erupt in such manner. So if they are born with teeth, then these are considered to be natal teeth. If within the first 30 days to life of life, you'll start to see the eruption, then those are considered neonatal teeth. Okay, so at birth, you already see the teeth, those are natal teeth. Okay, so up to 30 days within that time frame, then they are called neonatal teeth. All right, so keep those things in mind in case parents do ask you, hey, my child was born with teeth, like what do I do? I'm very scared, I don't know what to do in regards to that. So at least you can recommend whether or not to extract, especially since a lot of those teeth are not necessarily as strong periodontally. You may run the risk of aspirating, especially during feeding. So recommendations tend to lean either towards extracting those teeth, so that way the patient doesn't run risk of aspirating. And it's also very painful for the mother as well, especially when breastfeeding. So prepare the parent for that. If you need to extract, more than likely you will not have those teeth in that area until the permanent teeth do erupt. Okay, so always let the parent know in regards to that. When it comes to spacing, there are two different terms that I want you guys to keep in mind. There is the BAUME classification, so BAUME, and then there's also primate spacing, okay? So with BAUME, there are two different types. There's type 1 and type 2. What you see on your left-hand side is type 1. What you see on the right is type 2. The difference, as you can see, is the spacing. When we talked about when it came to flossing in our previous lecture, we said that spacing is good. It's great for oral hygiene purposes. It's also great, especially when you're doing your clinical examinations. It's easier for you to visibly see whether or not cavities are there. There's also an indication whether or not that patient will have crowding in the future. So if there is excellent spacing in between, there is a 100% chance that that patient will have a good amount of spacing and 0% chance of having crowding, okay? When there is no spacing, as you can see in the second picture, that runs a 50% risk of that patient having crowding in the future, and it's harder for you to have to visibly see if there are interproximal caries. At that point, you may want to move forward with radiographs just to make sure that that patient is not experiencing interproximal caries. Now, with the final picture down at the bottom, with primate spacing, it's located in two different places when it comes to the maxillary and mandibular arch. With the maxillary arch, it is going to be mesial to the canine, okay? Mandibular arch is going to be distal to the canine. The way that I help myself to remember is distal D, mandibular has a D, and that kind of helps me to remember that distal to the canine on the mandible is where the primate space is located, okay? Maxillary being the mesial to the canine. With general morphology considerations, when you're comparing primary versus permanent, you can kind of see, especially with the roots are more slender, they're more splayed out, and I'll show you a list of all the differences between the two so that way you can visualize. Okay, so with the crown of the primary tooth, you'll see that it is shorter, more narrow occlusal table, so that kind of constricts you when you're doing your restoration preps. You have more of a constricted constriction of the cervical portion, so that kind of helps with seating of your crown in a sense. So you have thinner enamel and dentin layers. You have enamel rods that are going more so occlusally. And then you have broad and flat contacts, and the color is usually brighter. So with the color contrast, a lot of parents do come into the clinic and they're always asking me, should I consider whitening on their 9-year-old patient or their 9-year-old son or daughter? I do tell the parents that when the primary teeth do come in, they are brighter and whiter than their permanent teeth when they do come in. So I kind of compare it to when you are baking a batch of cookies in the oven. If you take them out early, they'll be a little bit whiter. If you leave them in a little bit longer, they start to get that more browning and a darker look to them. So I compare permanent teeth to that second set of cookies that you leave in the oven a little bit longer. They're going to have that darker look to them. So when really it's more so the enamel. You have more thicker enamel in permanent teeth, so it kind of does give it that darker look. So, but anyways, so that's just what I kind of do to kind of ease the parent's mind about that. You don't want to do any type of whitening system, especially in mixed dentition, because there are just so many different colors and array of colors in that patient's mouth. So you don't want to have them having super bright teeth on one end and then like semi-bright teeth on the other end. So you don't want to, subject the child to that and then having to redo everything once they're in full permanent dentition. Okay, so with primary teeth, you have a more prominent mesiobuccal cervical bulge that you see in the primary molars. So that definitely does help with crowns. The incisors have no developmental grooves or mamelons. You will see the mamelons with permanent teeth. Just let parents know that they will kind of wear down with more eating of like roughage, like types of foods, so like apples, carrots, celery, things of that nature. They will start to even out. Right? More specifically with the central mandibular central incisors, they're symmetrically flat when viewed from the buccal. The crowns are about 1/3 length of the root. The cingulum is present on the lingual surface. With the lateral, mandibular lateral incisors, they're similar form to the centrals. They are usually longer. Incisal edges slope toward the distal, and you need to make sure that you're well aware of that line angle, which is more rounded. So if there is any type of crown fracture, that you're going along with the normal anatomy of that tooth and not trying to make it a even, like a square. Okay, so with the maxillary teeth, central and lateral, with the central, only tooth that has a it's the only tooth that has a greater distal mesial distal width than height, excuse me. Prominent cingulum, the incisal edge is straight. Okay, with the laterals, it's similar form as well. With the central, they're a little smaller and they're a little more round on the distal aspect. With the canines, you'll see on the maxillary that the crown is constricted at the cervical region. They are well developed in sharp cusps. The root is long, so more than 2 times long or twice as long as the crown. With the mandibular canine, similar form with the maxillary, what you'll note is the crown is shorter and narrower labiolingually. So with the first maxillary molar, it does have a unique appearance. They do have 3 cusps, so remember the mesiobuccal, distal buccal, and the lingual cusp. Do have a prominent mesiobuccal cervical bulge. So when you are putting a crown on and when you are going around and making sure that you are doing the prep, you may not want to touch the buccal too much, so that way you can get that good snap fit. For the mandibular first molar, also has a unique appearance, but it has 4 cusps, okay? So you have your mandibular buccal, distal buccal, mesiolingual, and distal lingual. Same, it has a prominent mandibular buccal cervical bulge, and with the mandibular, you have a transverse ridge. With the maxillary second molar, it resembles the permanent maxillary first molar, but it is a little bit smaller. The mandibular second molar resembles the permanent mandibular first molar, but it's smaller as well. So just keep these things in mind when you're doing your clinical examination, so you're not questioning and going back and forth. All right, so when we're comparing these two dentitions, you can kind of see um, how the patient is biting down. So you may want to look at their occlusion when you're doing the clinical examinations as well. So you're checking the overjet and overbite just to make sure teeth are positioned in the correct space. And then you also see how there's a different degree in terms of how the teeth look from patient to patient, but it should somewhat be similar to what you are reading textbook-wise. But you'll see a difference in some ways of patients that do exhibit bruxism to where teeth may look a little bit flatter. So you can kind of let the parent know, like, hey, is little Johnny or Susie like grinding their teeth at night? Because I'm noticing there's a little bit of wear because the anatomy looks a little bit off than what it normally should look like. All right, just a little bit more pictures of kind of like the difference between maxillary and mandibular teeth. Okay, so this is very, very important. You always have to consider the pulp when you're dealing with primary teeth. So the pulp, remember that it is relatively larger. The pulp horns are closer to the outer surface. So when you're doing your crown preps, just make sure you're not going too deep occlusally, so that way you don't go ahead and expose the pulp for that too, okay? Then you're having to end up doing a pulpotomy or a pulpectomy. Right, so there is a great variation in size and location of the pulp chamber. So mesial pulp horn is the highest, okay? Keep that in mind. So the mesial pulp horn is higher. The pulp chamber is shallow, so right where the top of the pulp is, the more occlusal portion of the pulp, to right where the root, the furcation is, okay? The form of the pulp follows the external anatomy, so same as with, kind of the same as with the permanent teeth, kind of. Usually a pulp horn is under each cusp, so keep that in mind, which is why we kind of went over how many cusps for the maxillary versus for the mandibular. With regards to the roots, you always want to remember that the anterior teeth, roots of the anterior teeth are narrower mesial distally, okay? Posterior teeth have longer and more slender roots in relation to the crown size. So you can kind of see how it's splayed just a little bit, and that kind of makes room for the permanent tooth bud. Molar roots flare more as they approach the apex, making room again for the succedaneous tooth. Apical foramina may be larger, and you may have accessory canals that are larger and more numerous. So implications. So progress of a tooth decay, so caries progression, is much faster in primary dentition. Why? Because the enamel is a little bit thinner as well as the dentin. So incipient lesions should definitely be treated as soon as possible. So when a parent, tells you, hey, they're just baby teeth, but isn't the cavity super small? Like, why can't we just watch it or just floss it through, whatever it is? Like, just let them know, like, hey, mom and dad, like, when it comes to children having cavities, they progress faster than what cavities that you and I may have. So you kind of need to not necessarily push the treatment plan on them, but just make sure that they're aware that if we leave certain decay in different places, that they may end up, 6 months later being bigger than what we see now. With restoring primary teeth, a couple of things to consider. Once again, so the enamel is thinner, so therefore modifications are necessary in the cavity prep. So broad contacts, you'll see that more. They need to be restored. Be aware of the mesial buccal pulp horn. They also may need to do SSCs if the proximal surfaces are involved. So even if you think you can do like a class 2 on a certain tooth, it may be more advantageous for you to move forward into an SSC, especially if it's encroaching on the pulp. So you also want to consider that you need to preserve the buccal cervical ridge to obtain mechanical retention for a stainless steel crown, like I said before. And I believe Dr. Tibby covered that in her lecture as well. Okay, so procedures in primary teeth, surgical procedures, things to consider. Conical anterior roots facilitate easy removal, so that helps. Flared roots of the molars, you may want to use caution as premolar buds are located between the roots. When it comes to pulp therapy, with pulpotomy, be very aware of perforation so you don't. Remember that the chamber itself is very shallow, so you don't want to dig your burr all the way in there, especially when you're doing your pulpotomy, because you'll end up having that perforation and then you'll end up having an abscess, or that crown procedure may end up failing in the future. Or you won't be able to obtain hemostasis during that procedure as well. So with pulpectomy, there may be some variable difficulty on molars due to the tortuous or irregular pulp chambers. So just keep that in mind, making sure that you're looking at your radiograph to kind of see how many canals you do have, how many roots you have, and just looking at the shape of the roots themselves. And then also, once again, just be aware of the tooth buds. So in summary, take a look at this slide, make sure you know it. Primary teeth have thinner enamel and dentin layers. The pulp horns are closer to the outer surface. The mesial pulp horn is much higher, relatively larger pulps, okay? The enamel rods run occlusally in the direction of the occlusion, okay, of the occlusal plane. And then cervical area is constricted significantly. Root flare as they approach the apex, and more tortuous or irregular pulp canals. Okay, so just keep that in mind. And that is it.